Welcome to this week's podcast by Step Kids Nutrition, where we explore matters related to pediatric nutrition with an invited guest. My name is Professor Rosan Meyer. I'm a specialist pediatric dietitian with almost 30 years of experience in pediatric nutrition. In each podcast episode, we will dive into the science and also practical tips behind topics related to childhood nutrition with an invited specialist. Whether you're a healthcare professional, a parent, or just interested in pediatric nutrition, you're at the right place. Welcome to this week's podcast. I'm delighted to invite again Professor Carina Venter, who is Professor of Pediatrics in Section of Allergy and Immunology at the Children's Hospital Colorado and University of Colorado Denver School of Medicine. Now, Carina, last week we spoke about allergy prevention, which is really your bread and butter. But actually, what is another bread and butter piece for you is that you've been a clinical dietitian for close to the same time as me. So I think close to 30 years. So registered in the US, registered in the UK, and like me, registered in South Africa. And the topic today is dietary management of food allergy. Again, like the last time, I want to kind of launch into it. What is the role of the dietitian in the dietary management of food allergy?
Hi, Rosan, and thank you for having me again. Yes, I'm going to answer your question in a second, but I have to say that, I think I'm a researcher in my genetic makeup, but the reason I do research is to answer the questions that parents ask me in clinic that I couldn't answer. And so I really, really love clinical practice as well. And so getting back to the role of the dietitian, I think, many people think, and even the American food allergy guidelines say that the role of the dietitian is to help with label reading. And yes, of course, we need to do label reading, but for me, that's almost the most boring part of the diet consultation. And the role of the dietitian is so much wider. I hate giving restrictive advice, and food labels is that bit of restrictive advice that we have to give to keep people safe. But the diet consultation really should focus on what we can have. How can life still be interesting? I know you're much better at me in terms of new recipe development and giving families ideas of how to cook. I do try my best, really opening up the diet. And then really one of our main roles is to make sure that children grow well in terms of height as well as in terms of weight gain. Because, it's very difficult sometimes to do that catch up length growth and catch up weight gain once we run into trouble with weight and growth.
Yeah. And I think that summarizes it very nicely. I'm surprised. I didn't know that it was restricted to kind of label reading in those guidelines, because in the European guidelines and of course in the UK, we're extremely, I would say spoiled, it sounds like it, that the guidelines suggest having a dietitian involved from the beginning of the journey. And as you said, we kind of expand rather than limit. And we now also play a role not only in the elimination diet, but also, as you know, the ladders, which will be another session of ours, and also oral immunotherapy. I did want to kind of touch on the difference for our listeners on dietitian and nutritionist, because I don't know, is there a confusion in the US as well, or is it just in the UK, this dietitian/nutritionist? What is the difference?
I think there's definitely a confusion, and I think it also doesn't help, that's just my personal opinion, that in America, dietitians are referred to as a registered dietitians nutritionist. So our abbreviation is RDN, even though I always use only the RD because I feel very strongly about the fact that I'm a dietitian. And, I think that the simple difference between dietitians and nutritionists are that dietitians are also medically trained. And so we can do what they call in America medical nutrition therapy. So we can advise people with diabetes, people with food allergy. We can also advise people who just want to eat healthy or look after their gut microbiome, which is what nutritionists can do. But nutritionists cannot give medical nutrition therapy, so they cannot consult somebody with diabetes or somebody with cancer. I think that's sort of like the basic difference.
Yeah, It sounds like it's even stricter regulated. So I think for the listeners, it's important to know that a registered dietitian, that's a protected profession. And also we are registered with either Healthcare Professionals Council in the UK, and you are in the US registered. And that means our training is very much regulated, and we have hospital training, as you were saying. For nutritionists, that's not the case. That means, in theory, in the UK, certainly you can do a week course on nutrition, call yourself a nutritionist. But I also don't want to be negative about registered nutritionists, because, of course, you can, it's voluntary, be a registered nutritionist and be an amazing nutritionist. But it is a very similar that we tend to do more clinical. Unfortunately, the lines become very blurred. We do find that there are a lot of what they call themselves as nutritionists doing alternative testing and all of those type of things, which of course we are legally not allowed to do as a
Of course.
dietitian.
But I think really getting back to food allergy in particular, you really want to see a dietitian.
Yeah.
And ideally, you want to see a dietitian that's had some further training in food allergy. We're doing a lot of work in America, training about 40 dietitians a year. We have a 10-month course through Food Allergy Research and Education, or in short, FAIR. We can put a link for you on the podcast as well. And then, of course, Rosan and myself have been involved for many years, I think almost 2 decades now, training dietitians and other healthcare professionals in the United Kingdom through Southampton University in particular, and then also in the past Imperial College London, to really have specialist knowledge about food allergies.
And I think, the food allergy specialist group in the UK from the British Dietetic Association does a spectacular job with the diet sheets. So, Carina, we both work in food allergy, and I wanted to ask you in regards to food allergen avoidance. Which are the nutrients that you see that you think, gosh, Rosanne, these are the nutrients are of concern when I see, if you think about the broad spectrum of patients you see?
So I'm going to start with the micronutrients. And Rosanne, as you know, we've also published a paper on that. The main micronutrients of concern really are vitamin D. We want to look at calcium, iron, zinc, iodine, if they have both milk and fish allergies. You did a beautiful clip on Instagram about iodine last week. And then, we also need to just make sure that they have sufficient intake of the B vitamins, vitamin C, really nutrients all over. But I think the top 5, as I've just mentioned, is really vitamin D, calcium, iron, zinc, and then iodine. Interesting, and I'd like your take on that, because I know you've done a lot of research on protein intake in particular. But I don't often find that protein intake, also calorie intake, in some children is an issue. And now that we're so actively introducing food allergens, all food allergens are good sources of protein. And most food allergens are good sources of calories. And so as we're doing introduction of, milk, egg, the nuts and seeds, I find that I rarely run into trouble now with sufficient intake of protein and calories in children with food allergies diets.
Yeah. No, I would agree. I mean, I see a very similar spectrum of micronutrient that are at risk. I mean, and that I want to kind of explain that as dietitians, doing a food diary and doing the history, we can establish risk. You can't say that is definitely a deficiency, but that kind of then is what makes us also special. We can then escalate and say these are at risk. We then kind of go and say these are the micronutrients that need to be targeted and tested, and that's how you test it. I would say it also depends on the type of food allergen you need to avoid. For me, and most of our data indicates that cow's milk is most probably one of the biggest, I think, risk factors because it's young. But you're right. Our data indicated also that most of the time you achieve a percentage of protein of 15%. So I think there is the misconception often that you need much more protein, but, and 15% is much more than what is currently recommended. I think where our data, and Carina, you were involved in the data where we looked at, is the protein energy ratio. So we showed that a child that was lower in weight, and if we monitored them again, if they had a better protein energy ratio through whatever means, then you saw a better catch up. So I think that's a kind of push for don't just give calories, think about protein and energy. And the trouble I particularly run in, if I run in cow's milk and they have all of these legumes and nuts, and then it becomes a bit more challenging. Have you got anything else to add?
Yes, I mean, again, also, quoting your wonderful data, we know that milk, as you've just said, is the main food when we avoid it, where we tend to run into trouble with growth. But also, the more foods the children are avoiding, particularly if you get to more than 2 or 3 foods, we know that we're going to run into trouble with growth. But one of the things I say to parents all the time, and I hope I'm not misquoting you, is I say to them, Rosan Meyer taught me that the most important nutrient for length growth is protein. And so I keep a very, very strict eye on length growth alongside weight gain, as you've taught me. And if we run into trouble with length, this is definitely at that point when I will make sure that we increase protein intake a little bit, just so that we get that catch-up length growth. Because as you know, there's fantastic data published from the group in Israel showing that if you don't actually address that length growth issue at a young age, we end up with adults that's shorter than other adults because of their food allergies.
100%. And you've not misquoted. And I think if there's one message that goes out today, is please do not stop measuring length. You often see a child looking really nice and chubby, but then actually when you start tracking their length, you see it comes down. And I think here an important factor to also mention is that there are other factors outside of the vitamins and minerals that can lead to that drop in length. That's ongoing inflammation. And as you said, think about the protein, but the micronutrients in particular that are involved in length are zinc. You also need to think about iron and vitamin D. And of course, if you're working a non-IgE mediated allergy, if a child has got a food protein-induced enteropathy, where you have the brush border damage, and I can't remember, I think you last author of that paper by Francesca, where we talked about the mucosal block. So I wanted just to highlight that you can have a functional iron deficiency. So you can, as a dietitian, I can do the calculation and kind of go, this child is having enough iron, but still can have an iron deficiency because of atopic disease itself.
It is, and the way that I explain it, I have a very simple mind when it comes to science. I like to read complex science, but then I have to digest it into simple. And this paper we did with Francesca, and I explained that to the parents as well. When you have ongoing inflammation in your body and you consume iron, the liver actually hides the iron. So you're eating it, but the liver's not letting go of it because the liver senses there's some inflammation. And so I say to parents, also you talked about enteropathy, but we see iron issues in children with food protein-induced enterocolitis syndrome or FPIES as well. And so I say to these parents, to really restore the iron levels, we're going to have get the ongoing inflammation under control. Now, I don't know if we want to discuss anti-inflammatory diets and an anti-inflammatory microbiome today. But again, getting back to the role of the dietitians, these are all the complexities and intricacies of managing food allergy that doctors may not necessarily have the knowledge, and even if they have the knowledge, they do not have the time. And so again, why it's so highly important if you have a child with food allergies to get to see a dietitian.
No, and I want to get you separately, because that discussion around the immune modulation with food and diet and using that as a vehicle for prevention and also for the management, I think really warrants a big discussion. Carina, I wanted to kind of think around the tips for avoiding these nutritional deficiencies. I think having a dietitian, of course, is around is amazing, but there are lots of people that will listen to this discussion to say, okay, but we don't have sufficient dietitians, or the pediatrician hasn't got the time to have that discussion. What are your tips, or have you got any tips in terms of avoiding deficiencies?
Yeah, so my first point is probably going to surprise you, but my first point is relax. And because
a good one.
Your child probably have deficiencies because they have some level of feeding dysfunction. Again, don't want to go into all the definitions of that today. And the best way to deal with that is relax. I actually saw a family just now before our call, and the mom said, the best advice you've ever given me was relax. And she said, the minute I relaxed, the child started to eat more. So relax, let the child guide you on what they will eat and how much they will eat, but keep offering healthy foods and do sit down as a family and set the example of eating. So that's my first advice when it comes to micronutrient deficiencies. The second thing is, again, highlighting the role of the dietitian. There may be hundreds of foods out there that's high in iron, but this child is only going to eat 2 or 3 of those. And again, working with the mom, saying this is going to work, this is not going to work, we're going to focus on this. So choose really alternative foods. The third level is to provide an appropriate supplement, not something that's going to provide 300,000% of what the child's supposed to eat. So choose an appropriate vitamin or mineral supplement. And once again, why it will be important to work with a dietitian. I see so many families when I say, are you giving the child iron or zinc or calcium supplements? They'd say, oh yes, because the child's on a very good multivitamin. Now, generally speaking, multivitamins contain just vitamins and no minerals. So we really need to make sure that we have an age-appropriate vitamin and mineral supplement. And then in the United Kingdom in particular, to some extent in America as well, we get these plant-based beverages or plant-based drinks that may be supplemented with some of the vitamins and minerals. And in that case, it's important to then choose a multivitamin and mineral that works well with the additional vitamins and minerals added to the plant-based drink to make sure the child gets what they need, but we're not necessarily over supplementing. At this point, I do want to stop and say that once a child have a deficiency in a nutrient, then of course the medical prescription of either vitamin D or iron, for example, will be much, much higher than what we consider to be normal or recommended by the dietary guidelines. In some cases, these very high levels may be needed, but that really is a medical treatment of deficiency, opposed to just making sure the child's getting everything they need.
And I'm glad you make that point. I often I do even get sometimes referrals saying this child has got not necessarily anemic, but has got low iron stores and so on. And I often say, putting that pressure on a parent to actually achieve those requirements. So I will do exactly like you say, relax, and then I top them up, but it will not be a therapeutic dose, as you were saying. It will be just a top-up dose. And you made the very good point of not going for, excessive amount. And I think that's a really good tip to give. If you don't see a dietitian, I often kind of say to parents, think, what are you excluding? If it's you mentioned fish, if it's just fish and you have other protein sources, that is pretty easy to absorb. But if it's a primary source, like, for example, milk, just to say, okay, I'm taking cow's milk out and I'm just replacing with coconut, which hasn't got enough protein, unless you've got something that's fortified. So it's always kind of thinking, what am I taking out and what am I replacing with? And, for those type of things, not the individualization, but my top tip is often saying you can get from the charities. And the UK, so you and me both have contributed huge amount to Allergy UK, Anaphylaxis UK, and to your US charities. We do provide them with diet sheets of simple guidelines. And actually for the British Dietetic Association, the food allergy specialists have got a one-pager that you can just download. So I would say that's a good start, but that does not replace that individualized advice, because the magic is from a dietitian is the individualization and making that special to you.
That is true. And I do want to get back to, sheets of information. Many of them are written by a dietitian. They absolutely have their use, but it can also be disheartening for parents when we give them a sheet like that, especially if the children have multiple food allergies. And I can take a very practical example. There's a sheet on high iron foods. But then when I see children that may have a milk and egg allergy and F-bites to some food, and we just go through the high iron foods, halfway through, I can see that mom is just so disappointed because I've had to cross out every second food. But it is then again, important to say the positive message. Okay, out of the 20 high iron food, the child can still eat 5 And so these are an additional 5 that's not on the list. And also getting back to fish, flaxseed is a very good source of fatty acids as well, and to some extent omega-3 fatty acids. Just thinking about outside of the box, on how to
Exactly.
get children to get
Exactly.
their nutrients.
And Karina, we've touched on, the dietary management, but actually I would say it's now 5 to 7 years, we've moved into a new domain, which is the active management of allergy. I think it's a term coined by our friend, Professor Adam Fawkes, the active management of allergy. But what is the dietitian's role in the active management of allergy? And what is active management of allergy?
Yeah, so in the first question, I focused just on the dietary management of food allergy because, you need to stop me when we start talking about the active management of food allergy. But this is just such a crucial role of dietitians, and you and I both love being involved in that field. The active management of food allergy really is actively trying to get the allergens into the child that they're already allergic to. And so that could be milk ladders, it could be egg ladders, it could be soya ladders, but also oral immunotherapy. Now, as much as oral immunotherapy is a medical treatment, which absolutely needs to be overseen by, allergist or at least a physician, the dietitians play such an important role calculating dosages, I can keep you busy for an hour about how to give a child 2000 milligram of sesame protein. And also, when the children get to 200 milligram of peanut and now they don't want to eat it anymore because they don't like the taste of peanut, how to disguise it other than just telling them to add some chocolate sauce to the peanut protein. So really, we play an important role on thinking of safe ways and also child-friendly ways, thinking about textures. It's very easy to say to a mom, just give this child a cookie. But as you know, many of our patients, will not eat cookies. So we had to come up with alternative ways and alternative textures of foods with similar allergenicity to a cookie, but a very different taste and texture. So yes, and then, in my clinics, and I know you do the same, I can't help myself. I have to address the gut microbiome because we know the gut microbiome is so crucial in tolerance induction. So when I do oral immunotherapy or ladder consultations, I definitely look at the overall diet diversity, and about ways to best nurture and feed the gut microbiome so that we have the best possible chance of tolerating the allergenic foods and inducing tolerance.
So you've managed to go through ladders, oral immunotherapy, active management. There's almost nothing for me to say outside of saying, I 100% agree with you. And it is, I think, for us who are older dietitian. I mean, I can remember in the 90s, end of the 90s, I'm not that old, but we had to tell the parents not to give anything. And it's just a total reversal almost of that advice. And I know last week we spoke about the allergy prevention. We brought up nuts and all of those sort of things. I want to say is we also see the active management. It might not be that your child is allergic, but that, for example, the physician, the allergist that we work with saying, look, high risk eczema, it's not just peanut, can you please get cashew and almond and those type of things. And it's trying to find those ways, as you said, that you can safely introduce it. I've also got, I'm sure, whenever I tell people saying, do you realize what the difference is between sizes of the same nut from the same packet? And I have measured the same nut 10 times of finding and deciding what is an average nut. So, all of those type of things. So whenever you go through oral immunotherapy, there's probably a dietitian behind that, regime.
It is, and not trying to make our job sound like, impossible to do. I love it, but I love every day in a food allergy clinic. But again, an important reason why, you need to see an allergy dietitian, and Rosan touched on some of that. We may be doing a ladder, but alongside the ladder, we need to do early introduction of some nuts. The child's also having oral immunotherapy to another nut or seed. They have feeding dysfunction alongside that. And then in between everything else, the eczema keeps flaring every now and then. And so it is actually a lot to manage, and to actually give that mom updosing sheet for oral immunotherapy, a handout on how to do a milk ladder, a handout on how to do early introduction of the other allergens, and then how to treat the eczema appropriately. It is just really too much to expect. It can all be done together very successfully, and we can get these kids to have normal diets much sooner than, at the end of 19.
Yeah, I know you work like me. I always say to the parents, I'm not a control freak, but I like to give, a
Yeah,
plan that
yeah,
they know, because we deal also with the fact that you get an email and saying, I'm here, and you kind of go, if you've not given a plan to say, I'm here, I'm struggling with that, then it becomes very difficult also for you and me as the dietitian that is involved. I wanted to, with the milk ladders, because we will have a separate discussion on the milk ladder, because it's a huge topic. I wanted just for people to kind of listen to this, to kind of think about the IgE and non-IgE, because if you can just quickly explain whether you do milk ladders and egg ladders, soya and wheat, but do you do it in both IgE and non-IgE, and how does it work?
yeah. So I'm just going to take 1 minute to just explain the different kinds of food allergies. We have IgE mediated food allergies. Let's just talk about milk and egg. You're basically going to have a little bit of milk, teaspoon of yogurt, half a bottle of formula, or you're going to eat an egg, a scrambled egg, or even perhaps an egg in a cookie or a biscuit, and you're going to have like symptoms within 2 hours. Normally it really is within 5 minutes. Hives, rashes, swelling of the face, perhaps some wheeziness. So that's IgE. Then we get the non-IgE mediated forms where the children have more delayed symptoms, like mainly gut symptoms like Rosan said, enteropathies, the projectile vomiting we see with food protein induced enterocolitis syndrome or FPIES, and then we get sort of like the narrowing of the esophagus with eosinophilic disease. I'm not going to talk about eosinophilic today and ladder, so forget about that one. And then we also have the kids with the proctocolitis or the blood in the stool, as we see a lot. When we first published the ladders in 2013, particularly the milk ladder, it was really just a way of getting milk back into the diet of the children with the proctocolitis and other gut symptoms, such as, reflux and diarrhea and some enteropathies, where we knew that they're not going to get anaphylaxis. But then we started to realize that the milk ladder has now been downloaded more than 500,000 times, getting close to 1,000,000 times, all over the world. And people were using it for FPIES and for IgE-mediated milk allergy. And then I thought to myself, oh my goodness, we've actually only ever calculated the milk protein in the food. And we've never actually tested whether the milk protein that's available to the immune system is similar to what we've calculated. And so Rosan published a paper with me on the milk ladders, and my paper, or I'm one of the co-authors on a paper on egg ladders, has literally just been accepted in pediatric allergy and immunology. And we got a long story short, we actually used the test for immune cells in the bloodstream. We use similar tests to test for those allergenic proteins in the food. And we found that for the most of it, we've got the ladders right, but we did have to do some fine tuning. And so to answer your question, I'm always very happy to use ladders in the milder gut related symptoms, but I'm now much more confident to use ladders in IgE-mediated milk and egg allergies and also in FPIES. Of course, again, this is where a dietitian with skills in food allergy come in, because when I see the children with proctocolitis, I may put them through the ladder, sometimes even in a week. That's perhaps a bit extreme. Most of the time within 2-3 months, I just get the foods in, get the child to drink milk. I'm not worried about anaphylaxis or severe symptoms. When I do it for IgE-mediated milk allergy and I do it for FPIES, it is much more graded. It's a slower process. And so, I use it for all kinds of food allergies, but my ladder process, and I mean, you and I work exactly on the same processes, are very different depending on which kind of food allergy I'm dealing with.
Yeah, and I think that's a really important message for the people listening to us today is to say that you can do it for IgE and non-IgE. Non-IgE, the concern is much less. And I by no means am minimizing the symptoms for non-IgE mediated allergy. It's just that we don't have the risk of the severe reactions. But it is a stepwise approach. And at all, both for IgE and non-IgE, you really want healthcare professionals that understands and has worked with ladders to be involved. It is a huge concern, and I've highlighted this to you, that I see, our ladder, the IMAP ladder, just on all kinds of blogs, all kinds of advice. And you go, no, that's not how we intended it to be. And no, and even for an IgE, I would say to parents listening, say, please don't do it by yourself. Have an allergist or a pediatrician that understands, with a dietitian that also understands how to work with it.
It is, and I saw a patient from a very famous allergist a few weeks ago, and he doesn't really refer for ladders, but we ended up with a referral, and I said to the family, so how did you end up here seeing me or Rosan? And the dad said, well, I look on the internet, everybody is laddering. And so I said to the doctor, we need to be laddering by now. And so, it is a great tool to get children to tolerate milk, but it really needs to be done under medical supervision.
Carina, we are now, whenever I talk to you, time goes very quickly, but we've actually done now half an hour. I know people that listen to you will not have much more time. I want to kind of finish off with, like I normally do, with some top tips on dietary management. And in particular, thinking about not those necessarily that are seeing a dietitian, but those that are saying, I'm waiting for a dietitian, what can I do before I see the dietitian?
So first thing is, again, I want to say, relax, go with the child. Second is, Rosan beautifully highlighted the important role of patient organizations. Safety after relaxation is the main thing. Get at least the information from these patient organization websites to make sure that you at least, at the best of your ability, read food labels and make sure the child doesn't actually come across the allergen. I think, again, even now with ChatGPT, he can help you to come up with alternative foods. It could be as simple as vegetarian food sources for a child that's milk allergic. Always check the advice you get on the internet, but that is at least a good starting point. If you really waiting to see a dietitian, but there may be, other sources of information about appropriate vitamin and mineral supplements for the time being. And then I think number 5 is just try at least, to offer your child a variety of foods within the foods that the child is willing to eat, but not just different food. Also play a little bit with textures. Think about mashed up food, think about crispy food, think about more soggy food, think about more runny food within the safe foods until you can see a dietitian that can expand the variety of food the child's eating, but also helping you alongside increasing your texture variety.
And I think that's the big thing is don't hold back on the weaning. If you I totally understand if you're worried about the allergens, but make sure that you already get some veggies in, expand the proteins that you're not worried about, fruit and those type of things. And I think the advocating, that every parent is the advocate for their child, and part of that advocation is, I always say this, get not only the weight but the length measured, because in many of the countries your acceptance of a referral goes much faster if there's concern also expressed, and you want that to be caught really early. And then, as you said, the supplementation, and download the free sheets that you can get already. Carina, I'm going to... Please.
I know we're out of time, but the breastfeeding mothers, look after yourself. You're almost all going to need vitamin D and calcium supplements, omega-3 supplements. Get a really good supplement in. Eat well, because so many babies, are thriving despite many food allergies, because mom is doing such a fantastic job at breastfeeding them. So really look after yourself and your own nutrition.
And that reminds me in any case, because you and me have got a running kind of interview with doing these podcasts, but breastfeeding really warrants as a topic by itself to have a discussion in the food allergic child. So I'm going to thank you for being here. I'm going to say to our listeners, this will be posted on YouTube. Either become a follower on YouTube or give us a thumbs up on YouTube. You will see at the end also all of the social media areas that you can follow from Step by Step Kids Nutrition. But thank you so much, Carina.
Thank you for having me.
Thank you for listening or watching this week's podcast. You can follow me on various social media platforms, which we'll share on the screen, or you can visit my website at rosanpediatricdietitian.com. You can also like this podcast on our Step by Step Kids Nutrition YouTube channel. Thank you very much.